x-rays. So overall, I'm just going to briefly run through each of these joints and the different x-rays that have been requested from the orthopaedic unit and how the different films are taken. So to start with, pre-operative shoulder replacement views. The request from the orthopaedic department has been to get an AP, so it's a true glenohumeral view rather than what has been done on some settings, what's called a general survey AP, and that's when they look at the scapula and clavicle but don't really have a proper shoot through the joint. Secondly, a scapular lateral, which is our Y view, and an axillary view. In contrast to this, in this little yellow box there, is what the radiology department regularly do, which is the glenohumeral view and lateral without the axillary view. So this is how our AP shoulder is done, patient rotated at 30 degrees, and that's our the shoot through the glenohumeral joint. The lateral is with the patient rotated at 45 degrees to the cassette, and the central ray is sent through the level of the humeral head, and we get the conventional Y view. With the axillary view, which is also from our request, an issue that's been raised from the radiology department is the difficulty with abducting the arm in order to complete that picture, but this is how it is done with our the aim to demonstrate the glenohumeral joint space as open, and including the proximal third of the humerus as well. For impingement cases, the requirements were to do an AP, so the glenohumeral view again, with internal and external rotation of the humerus, as well as a 30-degree caudal tilt to look at the subacromial space, a lateral, a scapular outlet view, and again the axillary view. So this is the difference between the internal and external rotation x-rays, and the 30-degree caudal tilt view to look into the subacromial space, which is this x-ray here. And the last add-on was the scapular outlet view, which is with a 10-degree tilt, so looking down at the joint space in order to get a good view of that subacromial space. And with calcific tendinitis, the request was for internal external views again, external rotation views, and the scapular lateral. And for instability, the AP and scapular lateral, which is the routine in radiology, but the add-on was to also request the Garth view, which isn't routinely done by our radiographers, and that basically involves a patient seated with their arm on the opposite shoulder. So you've got adduction and internal rotation with a caudal tilt again. This is one picture that I could find to show what that would look like, with the aim being to examine the posterior superior shoulder, proximal humerus, and also the glenoid.
Can you see that position?
Sure. Continue. For clavicle views, as we routinely see, are two views because the lateral is not very useful, with an AP, well, a straight neutral view, and with a 20-degree cephalic tilt, which gives us these two views. And for an AC joint complaint, from the orthopaedic protocols, the plan was to include a Zanker view, stress views if possible, and a cone view. The Zanker view is not routinely done by the radiology department. They usually do unilateral AC joint, and if they can, they do the weight-bearing views. However, many patients can't tolerate this, and so they do that contralateral view, which in order to compare the AC joint. The important thing here is that is that each shoulder is done independently to reduce the risk to the thyroid, and to also avoid, or to also get the cone view at the point of interest rather than a diverging beam to each shoulder. So the Zanker view is done with the patient sitting and the cassette behind the shoulder, and the beam is aimed in a 10 to 15 degree cephalic tilt, so looking up, and also with reduced penetration. As I mentioned, it's not routinely done by the radiology department, and a question was with this cephalic tilt, so looking up towards it, whether that would change our impression of the AC joint rather than the routine AP. Sternoclavicular joint views, which aren't seen very commonly from our orthopaedic protocols, the plan was to do a serendipity view, which is done with the patient supine and with a 40 degree caudal tilt, so looking down at the sternoclavicular joint. In contrast, the radiology department usually do PA view, so with the patient at 45 degrees, and the cassette or the central ray is targeted perpendicular to that SC joint. So that gives us this picture, which is difficult to see on there, but it's, if I show you the previous one that we had with the Zanker view, gives us quite a different image. Oh, sorry, serendipity view. And then for shoulder trauma, we do our routine AP and scapulolateral, but also the request was for an axillary view, which would be as difficult for a radiographer to perform in a patient that's in a lot of pain, obviously from fracture or other concerns from a dislocation. Moving on, sorry, yeah, sorry?
Why is it difficult now because of the routine?
Oh, okay.
They usually do it with a patient supine. When you have to rest the arm out, so it's
Okay.
It's not directly modified. It's a modified accelerator.
Yeah. I can't answer that, but I've heard them talk about it.
Yeah. We don't actually incur cassettes for the department. Usually, well, the reason we don't do an axillary, which is the SI, is because to do adaptation, make sure if it's dislocated, you're not necessarily. What you're talking about would be sort of modified, so it would be an exact axillary. It's just not part of that protocol, it's not something we tend to do. So, modification. I go to the Velcro view. No.
Go on.
You cassette behind the person, so the arm is slim like this, doesn't have to. Just lean back over the circle coming down. Yeah, well, these are things that need to be discussed.
Yeah.
So
I think
I do this view in CAS. Once I reduce the shoulder in CAS, why don't we do it? Patient supine, you get him holding onto the IV pole, rather than having a cassette in the axilla, which is difficult to put a cassette up there.
Yeah, there are other ways to do it. I'm not questioning that. There are other ways to do it, but a true axillary is actually to do that. And modifications are not going to protect the perpendicular for the reason that I can only speak as a radiographer. Yes, we can, and often, as I said to Rekha last night, often I've had patients that come in dislocated and come in like that, in which case I've not bothered with the wider view because they can't do that position, and you do an axillary in that case because there's not space.
Much like that, as you mentioned her lying down, and the head of the emitter down over the shoulder and the plate above, you get pretty much the same.
I agree, and you can do it, but again, most of our patients come with their arm on the side. It's more that abduction that most of our radiologists tend not to.
I think a big issue. Yeah.
And then you know, there's other modifications.
Yeah.
And I think that's the.
I have no issue with that. I'm just, you know, that's something that has to happen.
I think that's the primary issue, is that the communication with these guys, because often it's interns, say in the radiology department, they just get auxiliary view. They don't want to move the shoulder around too much because they think it's unstable. Yeah. Yeah. Yeah.
Could I ask you just about the emitter? Presumably, should be able to get a view straight up through the axillary with very little abduction.
I don't know the emitters actually. I think our tube heads are pretty much should be pretty much the same. I don't think it's really changed in size. As long as I've been here 16 years, it's quite big and bulky.
You need a very small to get shooted up.
Well, the problem is to get if you're going to get underneath,
yes,
you're actually going to get directly underneath there. You'll push it down the bed, but you also have to then get the arms a fair way away. So they've been our limiting factors. If there are other ways to do it, then that's fine. And if it's, which again, close problem is a good one. If our doctors that want to come out to
Do you have a mobile one?
A mobile one. It's slightly smaller, yeah. But again, you're going to then come to the risk with the quality of the film. So the output is not going to be the same. You're going to have a significant.
We mainly just want to see if it's in green or quality.
With the ultimate element actually, you know, where
I know better now. It's not a problem to get it.
I might just keep going because there's going to be a lot to talk about like this, and I suppose we need to plan to discuss it further. So moving on to the elbow. So routinely AP, lateral, and for specific cases, radial head view and lateral oblique. The radiology department in trauma situations will routinely do an AP, lateral, and a lateral oblique, except in the paediatric population we want to reduce radiation exposure. And again, moving on to lateral condyle fractures, AP lateral and an oblique again. So the AP elbow is done in extension generally, but often in trauma cases we have a patient that's unable to completely extend their elbow. In that situation, it's either done as a AP of the humerus, distal humerus, or of the proximal forearm. And this is a standard AP. The lateral view, sorry, I skipped before going on to this slide, is done at 90 degrees with the forearm and the humerus at the same level, so that the condyles can overlap. And then an oblique view can either be done with a medial or lateral rotation. The more standard one that's done is the lateral oblique, which is like this picture here, with the aim to try and have a better view of the radial head, or the proximal radius, and also the joint space. In contrast, a medial oblique, which is hardly done, is to look at the coronoid process, and is done in this way. Oh, sorry, here's my lateral. As I said, the forearm and the distal humerus at the same level, with the overlap of the distal humerus. A radial head view is done with the patient seated again, and with a caudal tilt of the central ray to get a good view of that proximal radius. And wrist fractures, so wrist injuries, the routine is to do a PA and a lateral view, and the radiology department also routinely do an oblique AP. Then it comes, I'll just show you those two. So the PA wrist, pretty standard.